the waiting room because
Will do.
I know we do have others that have registered for this morning, and we'll just kind of keep an eye on that. And then I just wanted to mention, thank you for joining us this morning. I think I know everybody on the call. I'm Joe Baumann, president of the Chamber. So welcome to this very important conversation, I think, about the science behind vaccination and the importance of why we need to have our communities vaccinated, not only from a personal health basis, but also from a business standpoint. We're not going to get back to having healthy, robust stores and restaurants until we can get behind this vaccination, behind this pandemic. So it has huge ramifications for the business community as well. So thank you. And also, lastly, I wanted to mention that if you have colleagues, friends who you think will benefit from hearing this conversation, probably sometime tomorrow we will have it up on our social media and also our YouTube channel. And we'll be sending out a link to everyone so you can pass it along to your friends and colleagues so they can hear this conversation as well. Before I introduce our speaker, I do want to thank, we have two sponsors for our, not only this session, but the whole four sessions in the series. They are Baumont Health, thank you very much, and Health Guided Gail Petricolo. And really, Gail, as you all know, is an immediate past member of the Chamber's Executive Committee, a longtime board member. She was really the driving force behind this series, not only helping to plan and organize it, but also explaining to us why it was important and why we should be doing it. So Gail, thank you so much. Okay, I'd like to introduce at this time our guest speaker. Dr. Nick Gilpin is both the Chief Medical Officer at Beaumont Grosse Pointe and the Assistant Medical Director for Infection Prevention and Epidemiology for the Beaumont Health System. He was appointed as Chief Medical Officer January 1st, 2018. So congratulations on your anniversary, Dr. Gilpin.
Thank you.
And he has served as the Assistant Medical Director for Infection Prevention and Epidemiology since January 2020. So again, we see a theme in the new year. Following 7 years as Medical Director of Infection Control for Beaumont Hospital, Grosse Pointe, in his infection prevention role, Dr. Gilpin has helped organize and lead Beaumont's response to the COVID-19 pandemic. Dr. Gilpin is an assistant professor with the Oakland University William Beaumont School of Medicine. He also serves as a clinical assistant professor at Michigan State University's College of Osteopathic Medicine. Dr. Gilpin earned his medical degree from Michigan State University in 2006 and a bachelor's degree in psychology from Albion College in 2002. Dr. Gilpin, I know you're a very busy person during this pandemic. So again, thank you so much for taking time this morning to lead this conversation.
Yeah, thanks, Joe. Thank you for having me. And it's good to be with you all virtually. So as Joe said, I'm Nick Gilpin. I'm the Infection Prevention Medical Director for Beaumont Health. I think that's the role that's certainly most germane to this discussion. And that's an interesting job. I'd say in an ordinary time, that's a pretty mundane role to have. Infection prevention medical directors spend a lot of time, kind of walking around hospitals and clinics and making sure that people are washing their hands and making sure that we have policies and procedures in place to do everything we can to keep our patients and our healthcare workers safe from infections. Just what it sounds like. Obviously, in 2020, that job took on a little bit of a different flavor. And I found myself kind of at the front line of this pandemic experience. I have been very fortunate to have a great team at Beaumont of medical directors and infection prevention, and also a great team of executives and physicians who have supported me. What I'm going to do today is talk a little bit about hopefully everything, but just little bites of the things that I think are going to be, relevant to having this discussion. I know we need to spend a fair amount of time talking about vaccines, but I think before we get to talking about vaccines, I want to talk a little bit about COVID, the disease, and then I want to talk a little bit about trends of what we're seeing in the community, and I hope that will help kind of bring the discussion home when we start to talk about vaccines. And then obviously we'll have time for questions. So first things first, just to kind of level set everyone on what COVID is and what COVID isn't. COVID-19 is a multi-system inflammatory disease, predominantly a respiratory disease, but it really affects multiple organ systems in the body. It's caused by a novel coronavirus. Coronaviruses are not new to us. They're not new to the planet. They've been around for, millennia. There are at least 4 major types of coronaviruses that cause diseases in humans. Most of these cause just colds and sniffles. But this particular coronavirus was something that our immune system had not seen before, which is part of the reason why it was so devastating to us. It's similar very much to other coronaviruses that have caused epidemics and pandemics in the past, most notably SARS. Many of you will remember SARS, which was a respiratory disease that started in Asia and eventually made its way over to North America and really devastated parts of Canada, particularly Toronto. This new virus, SARS-CoV-2, is very closely related to SARS, but with one key difference, and that is the potential for asymptomatic transmission, meaning I can spread this infection to other people without having symptoms. That's very different than the SARS virus was. The SARS virus was a much deadlier virus, and people who got sick with SARS did very poorly, but there was really no transmission from person to person unless symptoms were present, which made it much easier for us to control the SARS epidemic and get it, contained, as opposed to this virus, which, community transmission is high, transmission from person to person through respiratory droplets, talking, sneezing, close contact is very prevalent, and it's happening all the time, and it's happening among people who have no symptoms whatsoever. So it presents an enormous challenge from an infection prevention perspective. It's kind of like, invasion of the body snatchers. We don't really know who has this. And so it makes it really hard to reel it in. But suffice to say, the mitigation strategies that we have put in place that you've heard me and other public health experts talk about have really worked wonders to help contain the spread of SARS-CoV-2 and COVID, specifically masking, social distancing, washing hands, not going to work when you're sick, or frankly, just staying home when you're sick, quarantining if you've been exposed, and staying home for a minimum of 10 days or so after you've been diagnosed with a known case. Doing all those things correctly have really done wonders to flatten the curve. And so I want to just take for a second now, if I may, I want to share some slides that will hopefully help illuminate some of this. So here we go. So first things first, I want to show you a trend of what's happening in the United States. So many of us remember what the world looked like back in March and April when our little corner of the universe was just getting crushed with COVID. There were lines outside of our facilities for testing. We set up curbside testing sites at some of our Beaumont hospitals, and we were underwater. And the message to the public at that time was, stay home, stay away. Don't come to our hospitals unless you're frankly very sick. And that was because we really needed to protect our healthcare systems to be able to provide care for the communities that we served. Now, in retrospect, that was probably not the best message, because as we dipped into the somewhat lighter summer months of May, June, and July, when cases were down a bit, we experienced kind of a new phenomenon, which was patients weren't coming to the hospital, period. And so we had to pivot on our message to say, look, if you're sick, if you have, chest pain or shortness of breath or, abdominal discomfort and you need to go to the emergency room, you should still go to the emergency room. But there had to be a little bit of reprogramming to get people comfortable with that message. And then something happened in the later summer months. We started to see COVID pop up in other parts of the country, particularly the Midwest, out west, still parts on the East Coast were getting hit very hard. And we had really what I would call our second wave of COVID in the later summer months of July, August, and September. And then another wave of shutdowns happened, and we were able to get that under control. Throughout this time, Michigan really was not being hit too hard. But then fast forward to around October and November, we started to see a lot of cases in Michigan, but it was really focused in other parts of Michigan. It was really primarily in the Upper Peninsula and in the western part of the state. And then eventually that bled into our neck of the woods, and we had what I would consider our third big surge, which coincided with the fall. This was really related to a shift in weather, not to mention a shift in behavior. Remember, in the summertime, those of us that live in this part of the world, we love Michigan summer because it's warm and we can be outside and we can sit on our patio and we can easily socially distance with our friends. But when the weather started to get cold again, all of a sudden there was a push to people moving back indoors. Social distancing was more difficult. Masking was not perfect. And so that really helped drive this new transmission. The environmental changes also help the virus. The virus does not transmit as easily when the weather is warm and the air is more humid. It doesn't really move as well from person to person. When the air gets drier, like it is right now, and when there's less direct sunlight, like there is right now, those conditions really favor the virus being able to move from person to person more effectively. So we see a couple of notches in this current spike, and those notches almost perfectly coincide with Thanksgiving, which happened right here, which triggered sort of an additional wave of cases. And then we saw a slight downturn, and then along came Christmas, and that triggered another big wave of cases. And now for the last couple of months, or maybe several weeks, we've seen a pretty consistent downturn in the number of cases across the country. Our trend in Michigan really mirrors that, so I won't show you the same slide twice, but I will show you this heat map of what Michigan looks like and the total number of confirmed cases in Michigan, well over 500,000. Again, a lot of that happened in the Upper Peninsula where it's much more rural, but this was a lot of bleed over from the state of Wisconsin. Remember, Wisconsin got hit extremely hard in the early fall, and the Upper Peninsula really was the unfortunate beneficiary of a lot of case volume in Wisconsin. Michigan has seen most of its cases in the more urban parts of the state. For example, Grand Rapids, Southeast Michigan, and Saginaw and Flint have been hit particularly hard as well. Within our Beaumont facilities, our trend kind of mirrors what we've seen across the country. Remember, March and April was our absolute biggest peak. We had over 1,300 patients with COVID across all 8 of our hospitals at that time. That rapidly went down, and we had things under control for most of the summer. Now with our most recent surge, we got up to a peak of around 700 or so. And we've seen that on the decline now for the past couple of months. One thing that we've done at our hospitals to help with this, and I say help, I guess I should probably put quotes around help, is we've had to restrict visitors. And some of you may have experienced this personally or through friends. And it's not an ideal situation, to be sure. Normally, we really like having visitors in our hospital. We think it's important for patients to have family members or close friends be able to visit. It helps with messaging. It's good for self-esteem and morale for the patients. But we felt like this was the best strategy to keep not only our patients safe, but also to keep our healthcare workers safe as we were experiencing a surge. We're revisiting that idea now, but for a lot of reasons, there remains to be a lot of uncertainty in the air. So as we pivot now to what may come next, I want to throw out a couple of possible scenarios for you. So one possibility is, let's look ahead to the next several weeks or month, and what are the circumstances that might be stacked against us and might favor more new cases of COVID in the community? Well, for starters, we've got the Super Bowl coming up. We know that people are going to be gathering, maybe just large family gatherings, maybe multi-household gatherings to watch the Super Bowl. Could that drive more transmission? It certainly could. We know restaurants and bars are reopening, which I think many of us would agree is probably a good thing. We certainly want to see our economy be strong. But is that going to translate to more cases? Yes, it certainly could. I do think restaurants and bars can be done safely. I like to call that door number 3. Door number 1, close everything. Door number 2, open everything. Door number 3, open some things, but do it safely. I do think there's a way. But I also, my wife and I love going out to restaurants and bars, and I can tell you that not all restaurants and bars are created equal. I'm particularly concerned about smaller capacity restaurants and bars with low ceilings and poor ventilation and people taking off their masks and not being able to adequately social distance. Those are concerns. And then, of course, we've got these new COVID variants that I'm sure you've heard about. And the significance of these COVID variants is still a little bit unclear. Let me step back for just a moment. We know that this virus, SARS-CoV-2, it will mutate. This is not unexpected. We've known this since day one. Coronaviruses and many viruses for that matter, they will mutate. And they will mutate more if we don't stop them, if we don't control the spread of the viruses. More and more mutations will occur. And so you could say it's only a matter of time before it mutates into something that could be more difficult to manage. So when you hear about new mutations or new variants, I think an important question you have to ask is it fundamentally any different than what came before it? And the answer in probably 99 or more % of these cases is no. But when the UK mutation and the South African variant and the Brazilian variant were first identified, they did find that these particular variants were a little bit more transmissible. And in the case of the UK variant, possibly even a little bit deadlier. And so those are certainly red flags for us. So when you stack all those issues on top of one another, the Super Bowl, mass gatherings, restaurants and bars opening, and now variants in the community, including in Michigan, that could all favor seeing another wave of COVID cases in the not too distant future. The flip side of this is we now have a vaccine. It's certainly been a long time coming, but we now have a vaccine. And so as we hopefully get more and more people in the communities vaccinated, this could translate to fewer cases. The obstacles we have to overcome there are more logistical issues, making sure that we have enough supply to meet demand and making sure that we're pushing vaccine into the appropriate places. So I'm going to talk a little bit about the vaccine, but let me just stop sharing for just a moment and come back to you. Okay. So when we talk about the vaccine, I think we have to dispel some very common and very popular misconceptions. So I and others have said since the beginning that we're probably not going to get through this pandemic without a vaccine. What I mean when I say that is we will certainly get through this without a vaccine. We could. It would just take an extremely long time, and there's no guarantee that this pandemic would ever meaningfully end for us. We don't know how long immunity from this virus truly lasts when someone gets an infection. It could be 5 or 6 months. It could be a little bit longer than that. But if we don't control this with a vaccine, you're just going to see waves upon waves upon waves of surges for the foreseeable future until such a time when the entire population reaches that threshold of what we call herd immunity. And herd immunity is this idea, well documented, well described, that you need to reach a critical mass of protected people in a population to stop the spread of a disease. And for COVID, we think that that magic number is around 70 to 80%. That means 70 to 80% of people protected from the virus, either by having had the infection or having had the vaccine. That means the other 20 or 30% of people who are not vaccinated, who are not immune, are, by virtue of a larger herd that is protected, they will also have some protection. This is incredibly important. This concept applies to all scenarios where vaccines are commonly used. Think about measles vaccinations, for example. When there are certain kids who can't get measles vaccines. There are certain kids who have leukemias and lymphomas who are not able to get the live virus vaccines. And those kids need to have some protection, and they can't have protection themselves. So it's important for their herd that they live among to have protection to keep them safe. That's the concept of herd immunity. So we need to get to that magic 70 to 80% number, and that's going to be a tough nut to crack. There's not a lot of precedent for this kind of mass vaccination, at least in recent years. Historically, this is not our first major vaccine effort. Many of you may remember polio. And you'd have to go back, 50, 60 years to when the polio vaccine was developed. That was a process that took about 4 to 5 years. That was record time 50 or 60 years ago. This vaccine was developed in around 6 to 9 months. That gives a lot of people anxiety, but let me tell you, it should not. I've heard a lot of people, including our own healthcare workers, cite that as an example of why they feel this vaccine may not be safe. It was made too quickly. I think we need to break away from the idea that fast automatically equals bad. I think we have to respect the fact that this was a Herculean effort on the side of manufacturing to get the right people around the table to be able to do this quickly and effectively. Pfizer and Moderna, the two vaccine manufacturers that are currently available, both started working on this vaccine back in March. Back in March, many parts of the country were overwhelmed with COVID. So these vaccine manufacturers adopted a relatively new technology called mRNA technology, or messenger RNA, which is the technology that's used to make these vaccines, which is not only very safe, but it's also a very effective mechanism. And it allows the vaccine manufacturers to make these vaccines without having to use any live virus in their labs, which is very safe for the manufacturers. It also shaves months and months off the time to manufacture. So that's part of the reason why this particular technology was chosen. It's safe for the manufacturers, but it's also very effective once you have a finished product. And the vaccine works like this. You take a piece of messenger RNA, which is a sequence of base pairs or RNA or genome. And that is essentially a blueprint that the cells in your body can use to manufacture proteins. And those proteins will then trigger an immune response, and then your immune system will have antibodies, and it will all have been done without the virus ever coming near your body. It's pretty impressive. So when you get that injection in your arm, you're getting some small pieces of RNA, nucleic acids, which are taken up into your cells, which do not integrate with your own DNA. It can't happen. But your body will make proteins. Those proteins will be recognized by your immune system. Antibodies will be made, and you'll have a significant amount of protection on board. After one dose of Pfizer or Moderna, you'll have about 50% protection. After 2 doses, we're talking 95% effectiveness at preventing COVID disease, which is huge, which is really effective when you think about vaccines. Think about the flu vaccine, which many of us get every year. A good year for a flu vaccine is maybe 50 or 60% effective. We're talking about a vaccine that's 95% effective. I also like to highlight to people that this vaccine manufacturing process by both Pfizer and Moderna, even though it was done very quickly, was incredibly transparent. When you hear people on TV saying that this vaccine is safe and this vaccine is effective, you don't got to take it from them. The manufacturers were extremely willing to share their data with independent groups of scientists and physicians. They wanted people to look at their data and to check them to say, look, do you really think that this is safe? Do you really think this is effective? I was a part of a committee from Beaumont that looked at the data. The CDC appointed independent groups of scientists. The WHO appointed independent groups of scientists. And everybody essentially arrived at the same conclusion, that this vaccine is extremely safe and it is extremely effective at preventing COVID disease. But there is a lot of misinformation out there. And so I've spent a lot of time in the last several weeks really trying to correct some myths associated with the vaccine. And I think some of the most founded concerns about the vaccine are concerns about allergies and side effects. So to be sure, there are side effects with these vaccines. There are side effects with almost any vaccine. That's not a reason not to get the vaccine. You may have read that, a significant percentage of people that get vaccinated with COVID, with the COVID vaccine, will have some side effects. The vast majority of those, probably 95% of those side effects, are mild, last less than a day, and go away on their own. And the majority of those side effects are exactly the kind of side effects that you would expect to get with almost any vaccine, like a tetanus shot or a flu shot. A little soreness in the arm, you may feel a little run down, a little bit of fatigue, a low-grade fever. Again, all that lasts about a day. What I like to tell people is that is your immune system doing its job. That's your immune system ramping up to be ready to fight the fight. You're creating antibodies, you're having an immune response. And, as my dad would say when he would pour disinfectant on my cuts and scrapes and it would burn, he would say, that's how you know it's working. So that's what I tell people when they tell me about the side effects. I say, well, that means it's working. There have been some concerns about allergies with Pfizer and with Moderna. Slightly more so with the Pfizer vaccine. You may have heard that, I believe it was the day the vaccine was first released in the United Kingdom, there were, I think, 2 reports of people who had pretty severe allergic reactions. This is really rare. And most of these allergic reactions are fairly mild. What we do now to help mitigate that concern is when you do sign up to get your vaccine, you'll be asked a series of questions. And one of the questions is, have you ever had an allergic reaction, a severe allergic reaction, meaning anaphylaxis, trouble breathing, to any vaccine? And if the answer is yes, then we would advise that you either delay getting this vaccine or talk to an allergy specialist before getting it. If you happen to know for a fact that you're allergic to components of this vaccine, you should, again, not get this vaccine until you have a chance to speak to an allergist. Or alternatively, you could wait until one of the other new vaccines comes along that may be safer for you. But if you're allergic to tree nuts or peanuts or eggs or certain foods or, other environmental triggers, those are not reasons to not get vaccinated. You can still get safely vaccinated if you have seasonal allergies or other allergies. What we recommend is that you would just be watched for a period of about 15 to 20 minutes after you get vaccinated, just to make sure that everything's okay before you leave. Because the majority, probably 90% of all the reactions that do occur are immediate reactions, meaning they happen within that 15 or 20 minute window. There have also been concerns that I've heard from people related to pregnancy and breastfeeding and fertility. Some of this is founded, some of this is not founded. So let me dispel some of the myths. First of all, there is a lot of precedent for vaccinating pregnant women. We recommend vaccines. We recommend a tetanus, diphtheria, pertussis booster for pregnant women at every pregnancy. We recommend pregnant women always get the flu shot. We recommend a pregnant woman who's not vaccinated against hepatitis B gets a vaccine for hepatitis B. So there's lots of precedent for pregnant women getting vaccinated. Unfortunately, when these studies were done for the COVID vaccines, they were not looking for populations of pregnant women to vaccinate. They rarely do. Whenever phase 3 clinical trials are done, pregnant women are typically not high on the priority list for inclusion in those studies. But they did have some women in the studies that were either pregnant or became pregnant shortly after getting the vaccine. And there have been no sign of any issues with those women. In fact, major physician groups and societies, the American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine, which are two of the big dogs, have both come out with very strong statements to say that the vaccine should not be withheld from pregnant women. Pregnant women should be informed that we don't have a lot of data, but it's certainly not a reason not to. And I can tell you that a number of our pregnant healthcare workers have gotten the vaccine. Happy to report that those that have received it have done very well. I've heard concerns about breastfeeding, and this comes from the initial studies that were done. Again, they didn't really look at that data, but let me remind you that there's precedent here as well. There's a lot of suggestion that breast milk includes antibodies from mom to baby. It's a good source of immunity for a newborn. So it stands to reason that if mom is vaccinated and develops antibodies, then by virtue of breastfeeding, some of that immunity will pass from mom to baby safely. We know this is true with other vaccines. We know this is one of the reasons why breastfeeding is encouraged in newborns, because newborns can't get vaccinated, mostly in the first few months of life. It's not recommended because their immune system is too immature. So that's another reason why breastfeeding is often recommended for newborns to help with immunity. So there's no real concern in my half for breastfeeding. And then as far as fertility concerns, I'm not sure exactly where this rumor started, but there is kind of a pernicious myth that this vaccine will somehow cause infertility. Completely false. I have no evidence to support that whatsoever. And again, I believe that all the reputable scientific organizations, including the CDC, have all come out and basically said that there's no basis in fact for that myth. So far as distribution goes, let me go back to my slides for just a moment. So I mentioned that about 1.7 million doses have been distributed throughout Michigan, and that's about a 50-50 Pfizer to Moderna ratio. And of those 1.7, about 1 million have been administered. Now, why have we not given 700,000 doses? Well, that's because many of those doses may have been scheduled but not yet given. Many of those doses may be held back for second doses, so that we ensure that people have that there's enough vaccine to give people the second dose when it's due. Beaumont's data looks like this. We've given, I believe now the number is over 80,000 doses administered. We have the capability to give between 3,000 and 9,000 doses per day. Unfortunately, our allocation of vaccine has diminished a little bit this week. Some of you may have heard that the distribution is shifting, that healthcare systems who have really been sort of the primary distributors of vaccine are sort of going to be dialed back a little bit, and you're going to probably have more vaccine distributed to public health and to retail pharmacies. So that's a pivot that's going to be happening over the next several weeks. And frankly, I'm okay with that. I think it's important to make sure that we're getting vaccine into the communities where people live. I think it's important to create access. And healthcare systems like Beaumont and Henry Ford are going to be there to help. I mean, that's what we want to do. We want to help in any way that we can. We don't want to own the whole thing, but any way that we can help and make sure that people get vaccinated, I think that that's important. You can go to michigan.gov/COVID vaccine. There's a link here where you can click on and you can find a site within your county. I'm going to take a wild guess and say that most of you probably live in or work in Oakland County. So I will share with you the Oakland County vaccine website, which is oaklandcountyvaccine.com. There's a link here to click on, or a button to click on to save your spot. Oakland County is using a first come, first served distribution. So don't try to sign up more than once. If you go on there once and you put your name in there, you'll get put into a queue. If you think you're going to game the system by going in 2 or 3 or 4 times, each subsequent time that you go in, you're only going to put yourself at the back of the line. So it's best to just log in, sign up once, and be done with it. And when your name gets called, they'll make sure to contact you. I spoke to the Oakland County Medical Director, Dr. Russ Faust, this morning. He might not want me to share this information, but I'll tell you anyway. There is a significant number of people that are on that waiting list. It's over 300,000 people on that waiting list, which is a huge number. But as the state starts to allocate more vaccine to county health departments and less to hospitals, they should get through those numbers much more quickly. And then, of course, I have to talk about Beaumont. We have beaumont.org. And at the top of the screen, when you go to the website, you'll see this My Beaumont Chart button. You can click on that. You can sign up for My Beaumont Chart. Make sure that your information in that My Beaumont Chart account is accurate, specifically your email address, because that's the mechanism through which you will be contacted. We are using a sort of random lottery system. Random lotteries are not perfect. I will be the first to admit that, but random lotteries are fair. And it would be really difficult, maybe even impossible, frankly, to develop a perfect distribution model taking into account everybody's age and medical comorbidities and everything that we think of with vaccine distribution. So in the interest of time and expediency, we felt like a lottery would be a reasonable choice. We also feel like as we get more vaccine available, the distribution bottlenecks that we're experiencing right now will hopefully improve, and it'll be a much more fair and smooth distribution process. So let me go back to myself here. Now, there's probably a lot of questions about vaccine distribution, and I'm certainly happy to take those questions in the Q&A portion of this. But I guess the last thing I want to leave you with is, just to highlight something that I said a little bit earlier. I think our message really needs to be to the communities that we live in and we work in, that we all want to go back to life as we knew it. We want to go back to sort of pre-COVID normal. And I truly believe that to get back to something that resembles normal, a vaccine is essential. Getting to a 70 to 80% vaccine rate for our community is going to be a very difficult hill to climb. I'm not completely sure that we're going to be able to do it just out of the goodwill of people wanting to get vaccinated. I think that there's probably going to have to be some type of incentivization for people to want to get vaccinated. That could, and this is all very speculative, but that could look like immunity passports. That could look like people that want to get on airplanes have to show proof of vaccination. That could look like, I don't want to say the nasty bad word mandate, but there could be some mandating of vaccines in some certain populations. Again, this is speculative, but just think about that for just a moment. There's a lot of precedent in our country for mandating vaccines for certain populations. We mandate vaccines for kids going to public schools. We mandate vaccines for healthcare workers working in hospitals. We mandate vaccines for people that travel to certain countries. So there is some precedent there. And so I wouldn't be surprised if there's sort of a combination approach of incentivizing people through immunity passports and mandating in other situations. At this point, I don't think there's much appetite for mandating the vaccine, mostly because it's still so new and it's still technically under what's called an emergency use authorization, which means we really can't mandate it for large chunks of the population. But once it gets final FDA approval, that's a conversation I'm sure this country is going to have. So why don't I leave it there, Joe, and we can maybe take some questions?
Perfect. Thank you so much, Dr. Gilpin. You've actually addressed several of the questions already that were in the chat box, so I'm just going to pick and choose those that I don't think have been covered yet. As it relates to the figures that 95% rate to prevent COVID by Pfizer and Moderna, is it not true then that people are getting COVID again after getting the vaccination, but rather were potentially infected prior to being vaccinated?
That's a good question. So there have been reports of people getting the first dose and then roughly 10 to 14 days later coming down with COVID. We've had a few of those people in our healthcare system. There was a report from, I believe it was Israel, that found a semi-alarming number of people who came down with COVID after getting between their first and second dose. First of all, 95% is not 100%. That's one thing. After the first dose, you really only have about 50% protection on board, which is not sufficient to really provide the protection that you need. What I suspect is happening in these situations is there's a false sense of security when someone gets their first dose of a vaccine or even their second dose. It takes about a week to 10 days for that immunity to ramp up. So if I get my vaccine today and I think, oh, I feel great, good, I'm glad you feel that way, but you still need to wear your mask. You still need to socially distance because you're potentially still vulnerable. It doesn't mean you couldn't get COVID tomorrow and then you'd be sick. So that's one message I think we have to push here. The other thing I think is that, we know the vaccine is extremely good at preventing disease. One question we don't yet have answered is, does the vaccine also prevent transmission? Now, this sounds a little weird, but it's an important concept. So people might say, I got vaccinated, I'm vaccinated, my wife's vaccinated, that means we don't have to wear masks anymore. Not true. It's theoretically possible that you could be vaccinated, protected against disease, but if someone were to cough or sneeze in your general direction, you could actually hold the virus in your nose or your upper airways and potentially pass that on to others. Again, it sounds kind of weird and it sounds a little theoretical, but that's a question we really need the answer to. And until we have the clear answer to that, it's going to be important that even among the vaccinated public, people still continue to wear the masks and do all the things that the rest of us do. They'll be protected against disease, but transmission is still a question.
Thank you. You touched on this a little bit about vaccine mandates, but this is a little more specific in that, do you believe hospitals will mandate that all employees have to have the COVID vaccine just like they do for the flu vaccine? And can a patient request that the clinician that is treating them is vaccinated? For instance, a woman having a mammogram where the technician is very close to the person for a period of time.
Well, I mentioned the emergency use authorization, and that's been one of our big barriers. Now, I live in a different world, and so my perspective on vaccines is maybe different than the average bear. I've taken a very diplomatic approach to this. I want our people to want to get vaccinated. I don't want to have to mandate the vaccine. I think that that's a tool in our toolkit that I would prefer not to have to use. And we took a poll of our staff and we found that even among our healthcare workers, a significant percentage of them do not wish to have the vaccine be mandated. So for the time, we have taken a big education blitz to really encourage people to be vaccinated. We vaccinated, Beaumont has 38,000 employees. We vaccinated over 25,000 of them. So we're certainly well on our way. And of those 25,000, that is the vast, vast, vast majority of employees who have frontline contact with patients. So our nurses, our physicians, our techs, our respiratory therapists, the vast, vast majority of them have gotten vaccinated. As far as the question about whether someone can request a vaccinated versus not vaccinated employee, it's a good question. I don't know that I really know the answer to that. And the answer is probably not, because there may be health privacy, laws that have to be taken into consideration for that. But that's a very good question.
The next question is, has there been any additional research regarding small children as transmitters of COVID?
There has been. And, back in the summertime when I first started looking at this, there was sort of a mixed bag. There were some studies that were suggesting that transmission among children was not so much a thing. And then there were others that clearly showed that there were outbreaks in schools, and it was clearly related to asymptomatic transmission among kids. The dust has settled. Yes, it does look like students and children under 18 are capable of getting COVID and spreading COVID, but it seems like that is a lower risk than the general population. Pivoting to the vaccine, Moderna and Pfizer did not look at kids in their vaccine trials. We do not know if these vaccines are effective for children under the age of 16. I can tell you they're doing those studies right now. I can tell you that from a public health perspective, we need to make sure that our teachers and the people that are in our schools are vaccinated. Children are going to potentially still be at risk, but that risk is going to be lower than the quote unquote, adult population. And then hopefully in the next couple of months, we'll get data to suggest whether these vaccines are effective for kids, and then we can proceed accordingly.
The next question is, and you might want to also address the backlog and the waiting lists, but the question is it okay to sign up at more than one site for the vaccine, for instance, with Baumont Health and Oakland County?
Absolutely. In fact, that's exactly what I would do if I were you. If you want to get vaccinated, I would go to, any county that you live in, work in, or play in. I would go to their website. Any healthcare system you've ever touched, I would go to their website. Soon, probably retail pharmacies will get in the mix. So you'll have your CVS's and your Walgreens and your Rite Aids. I would just fan out those, requests and see who hits first. I think that's completely fair play. One of the challenges we're having, and I'm guessing it's not a problem with this group because we're having a virtual meeting right now, but we're working really hard at the state and county level to make sure that the vaccine distribution is inclusive, that we're not only catering to people who have internet access, but we also need to remember that there are enormous chunks of the population that may not have access to internet. That may include, elderly patients. That may include people in their 80s who just don't have computers or don't know how to use computers. So we've really tried to set up a fair distribution for that. We have call centers. Those call centers have been, there's no nice way to say it. They've just been kind of a mess. And I know the Oakland County's call center has been a mess. I know Beaumont's has been a mess. We're trying to get those staffed up. That's a high priority for us. Again, to make sure that we can, get everybody a vaccine that is eligible.
I know that there are individuals who are opposing getting vaccinated for myriad reasons. One area is I've heard people say they weren't going to get vaccinated for religious reasons. And that's connected to the fact that some vaccines and medications over time have used fetal stem cells as part of the development of the vaccine. Can you address that a little bit?
I can. I participated in a town hall with a gentleman named Reverend McDonald, who's a Baptist minister and a leader in his community, and he addressed that issue, which I did not know at the time. And I believe the Pope, Pope Francis, has also come out and stated that this vaccine, the Pfizer and Moderna vaccines, were not manufactured using stem cell technology, so they are considered safe from that perspective. In fact, I believe the Pope even went so far as to say that we have a quote unquote moral obligation to get vaccinated. And I won't, get into the morals and ethics of vaccination, but I'm glad people like him are advocating for getting vaccinated. I think that's important for people to hear that message.
How about the other vaccines that are coming close to being brought to the public?
Yeah, good question. I don't know. I think so. The J&J vaccine, I have not seen their press release because they have still not yet applied for emergency use authorization. All I've seen is probably what you've seen, which is the news reports that have shown that it is about 60 to 70% effective and prevents disease and hospitalizations. But I don't really know much more than that. Likewise with the Novavax, and likewise with the Russian vaccine, Sputnik V. So probably those are the next 3 vaccines that we'll see making it to market in the next several weeks. But hopefully before those vaccines get FDA approval, the process will look like it did for the other vaccines. There will be a big data dump. There will be independent councils of scientists that will look at this data, and we won't just take their word for it. We'll make sure that it's safe and effective for our communities as well.
Just a clarifying point, since you brought up Beaumont and Beaumont My Chart, so anybody can go and register with Beaumont regardless if you're a current patient at Beaumont? Is that correct?
That's right. So initially we had suggested that we only wanted to keep it to people who had, an existing relationship with Beaumont. After some discussion with our ethical team and our groups, we decided, no, it's not a good idea to limit. We should just make it as available as we can. It's fair, it's ethical. So even if you've never been to a Beaumont facility, you can sign up for a My Beaumont chart, and if your name gets called, you will get vaccinated. Now, I don't think I mentioned this, but I suspect many of you probably know this. We are following state and CDC recommendations for prioritization. Right now, we are in group 1B. 1B means people over the age of 65 and essential workers like teachers, police workers, firefighters. We have not yet dipped into the population of 19 to 64-year-olds. We don't know when that's yet going to happen. But in anticipation of that, we still recommend people get themselves signed up through MyChart, because once it is, that'll be the way you'll be contacted.
So, Dr. Gilpin, viruses by their nature don't really ever go away. They may be reduced in some form, but we see that with the flu, right? So every year, whoever determines what the proper soup should be in the vaccine for the flu, and every year we're encouraged to get a flu shot. Is it anticipated that 2 years from now, 3 years from now, we will just continue to be vaccinated against COVID-19 as we are for the flu?
It's possible. Really good question. A couple things I want to hit on. Yes, we know that immunity from the COVID vaccine from the studies lasts at least 3 to 4 months. In reality, it's probably much, much longer than that. I've heard both the Pfizer and Moderna manufacturers say that they expect immunity to last at least a couple of years. That is longer, we think, than the immunity that you would get from getting a COVID infection, which is interesting because normally it's the other way around. Normally, the immunity that you get from having an infection lasts longer than the immunity that you would get from the vaccine. The COVID vaccines seem to be a little bit different in that regard. I believe that this coronavirus will become what we call an endemic infection, meaning it will join the other 4 or 5 coronaviruses that are already in the community. But because we will have some community immunity to the infection, it will not make us as sick And it will probably, in a period of 2 or 3 or 5 years, once we've gotten through this pandemic completely, it'll be another virus that causes the so-called common cold. That's probably what happened with the other coronaviruses. At one time, they were probably sources of major pandemics or epidemics, but over time, there's been community immunity that has sort of made them less virulent or dangerous, and now they're just common colds. So I don't know that we're going to necessarily have to get booster shots for this or get annual vaccines for this. But one possibility is that if the virus continues to mutate, then we may need to get some additional vaccines on hand to handle some of the new variant strains. So to be continued on that.
So one issue that we're hearing a lot about as well is, it's not really known what the long-term medical effects are going to be on individuals who've had the disease. I'm sure we all have people in our spheres of influence who were tested positive and either were asymptomatic or had very minor symptoms, but nobody knows what's going to happen 2 years, 3 years, 5 years. How is the medical community going to track the long-term effects of COVID-19?
Oh boy, that's a really good one. Still lots to learn. I gave a presentation a few months ago to a group of family medicine doctors about the sort of long haulers with COVID and what is this really going to mean for us. First of all, it's important to point out that the long-term symptoms of COVID are really sort of the consequences of a dysregulated immune system. It's not the virus itself. It's more your immune system's response to the virus. And so we expect that whether it takes a month or 3 months or 6 months or 12 months after the fact, things will eventually return to normal. And there's precedent there. We've seen this with other infections as well. So I think the message right now for people who are experiencing some of the long-term effects of COVID is really a message of patience and reassurance that, this is not going to be your life forever. We don't really know yet how long this is going to last, but all evidence seems to support that people do return to work, people do return to normal. It's just a variable amount of time. And another thing that I think it's important to highlight is that even now, a year in, we really still don't have very good treatments for COVID. Our antivirals are not that great. We use steroids, which are not that great. So really the best offense here is a good defense, is making sure that you protect yourself and get vaccinated because there's just not much else we have to offer.
We have time for one more question, and it comes from the chat box. The question is, I know Beaumont and other health systems have invested a lot of time and money in creating vaccine sites and have many qualified people to administer the shots. How will CVS and other drugstores handle finding qualified staff to get shots in arms?
Boy, that's a tough one because that's been our number one challenge, has been staff. Staff one, infrastructure two. And you're right, we put a lot of resources into standing up our vaccine clinics at Southfield and Dearborn and Troy. I know Henry Ford has done the same. It's a zero revenue job, frankly. I mean, we're standing up all these different sites to distribute vaccine. We're doing it for free. That's going to be tough for these big box retail pharmacies, right? So I don't really know, frankly, how they're going to do it. It may just be that they're going to have enough volume. I mean, there's a CVS or a Walgreens or a Rite Aid on almost every corner. So it's possible that they're just going to, handle it that way. They'll have a few people at each site to be able to administer vaccine, and they won't have to distribute, at these huge sites. But I also know from discussions with the state that another vehicle for distribution by way of the counties is to do things like what they're talking about in downtown Detroit, setting up the TCF Center and some of these larger facilities, possibly even bringing in FEMA or the National Guard to help set up mass vaccination sites in communities, maybe 1 or 2 per county. So when you look at all the different distribution methods, you've got Beaumont and Henry Ford, you've got the county, you've got CVS and Walgreens. When you add it all up, you've got a pretty good multidisciplinary vehicle for distributing vaccine. It ain't perfect, but it's probably as good as anything else we can do right now.
Excellent. Thank you. Well, we have come to the end of our time. Dr. Gilpin, thank you so much for leading this really important discussion and conversation. The Chamber, since March and the beginning of all this, has worked very hard to keep our members informed and updated and with the most accurate information that we can find from credible sources. And this was just terrific. And I think it will dispel, based on the questions that came in the chat box, some rumors and some myths that may not be true. So hopefully now all of us will spread that word as well, and we will get people to feel more comfortable about becoming vaccinated so we can return to whatever the new normal is going to be. I do want to thank our sponsors again, Baumont Health and Health Guided, for underwriting the cost of this program. We really appreciate it. And we encourage everybody to come back next week for the second session, which is Kelly.
I'm sorry, I was on mute. It's supporting employee health and wellness, and Gail Petricola will be moderating that. It's with Michelle Hansen. No, I'm sorry, it's with Kristen Baker from HRAA and Dr. Hallie Armstrong, who's an integrative wellness doctor at Beaumont.
Great. So again, thank you all so much for joining us this morning. Hopefully you found this to be a worthwhile use of 1 hour of your time. And we hope to see you all again next week. Take care.
Thanks, Joe. Thanks a lot, Nick.
Thank you.
Thank you, everyone.